healthcare. The objectives below are what I hope to obtain in this project. And my project includes patient education. My current practice setting is within an acute care hospital. My current unit is medical surgical, where my population includes telemetry, elective, non-elective surgery, chronic conditions, among others. Current acute care education consists of paper forms handed to and explained by the staff, patient portal access, and a verbal education, again, verbatim by the staff. Patient education benefits to technology integration. It is available when the patient is ready for it. It maintains privacy. The content is ever-changing, never stale. Increased patient satisfaction because they can access it when they want and how they want, and increased compliance in their medical conditions. Research articles that I found important in my situation include internet-based patient education versus an office visit education. So patients were asked to complete surveys on their emotions preoperatively, perioperatively, and postoperatively. On emotions such as fear, anxiety, depression, nervousness around their operation. The study found that fear can be better controlled with internet-based education because the patients can connect and absorb that information better at their own convenience and in their own time, and not when a practitioner is telling them verbally. Second research article that I found was patient education offered in waiting areas. Patients were given tablets with patient information and education on them, preloaded, and they were able to go through that while they waited for their physician or their practitioner to come out. Patients were more likely to be satisfied with the visit, which then led to more compliance with their follow-up care. They were more likely to keep their future appointments, and then they were more likely to comply with their treatment plan. Some ethical and legal implications include practices are not yet established and ethics are not as fully explored in this realm. So we're still looking at something that's very new in healthcare, using technology and the internet to share information with patients, and we're not quite where we need to be in terms of the policies and the expectations. Patient privacy, confidentiality, and limits to public disclosure are a big red flag for patient care in terms of privacy. We need to make sure that patients are getting what they need and when they need it. Policies developed for practitioners to consider exposure of privacy. They are asked to consider how open and how exposed social media is for their patients before considering using those mediums. And then Adams's quote, insufficient protection of patient and professional rights could adversely impact the doctor-patient relationship. Obviously, if you feel that your doctor is not being safe with your privacy, that's not going to bode well for a patient. Creating change. So my idea would be a post-discharge education. A website or a web-based application with a patient's tailored discharge instructions. It would include links to communities of like patients so they can talk with others that have similar conditions or surgeries, and then links to trusted sites for more information. Obviously, we know that Google will lead us to any site that we want to go to, but those sites may not be reliable sources. It could be linked to their patient portal for easy access and safe access, and then HIPAA compliant, of course. Why do I feel that this is necessary? When patients are being discharged from the hospital, They're handed a packet and a nurse goes over the information with their conditions. Even during the hospital stay, they can't possibly absorb that information completely. They're in a rush to leave the hospital. They're under the influence of narcotics or anesthesia. I feel that family, of course, with the patient consent, family reinforcement and education could be helpful in this situation. And that family and patients didn't think to ask questions before they left or during the stay. So this post-discharge education could be very helpful in answering those. The goals that I intend to achieve would be to reduce readmissions, curtail post-operative infections, and increase patient satisfaction. Supporting this change, Wong and Lee, 2017, talk about interactive education, ensuring understanding. It's better than a static piece of paper that they read. They can look through, they can search terms to answer questions. And then patients today are open to computer programs for medical information. They find that those are easier or more reliable than other forms. Heikkinen in 2012, using regulated web pages, patients have a reliable source of information. Again, we don't need to go to Google or WebMD. Supporting this change, Sorothea and Kapupara in 2017 talk about tech-based education providing the best opportunities to learn about health. And the following points for tech-based education include the just-in-time availability when they need to learn it, private learning environments, immediate reinforcement of that education that we've already given to them, an interactive environment, and access to patient support communities where they can learn even more from their peers. Our planning committee would include the informatics nurse, the executive team including the CIO, web designers or user experience designers or application designers, whichever route this project would go, to design the physical, and then nurse educator for all of the patient information that's going in there, medical heads of departments like surgeons, what information do they want to include in there, and those involved in budget making. Training for staff. So training for frontline staff would be pretty minimal. Education on how to direct the patient to the website, and training on how to show patients to access their patient portal, which will direct them to the website, would be two main things, which would be pretty minimal. And also just establishing the process for nurses to add it into their discharge instructions. Training for patients, again, the goal would be for the website or application to be intuitive, so we would not need education on how to use it. And then ongoing training would only be if changes are made to the process or the access itself. Evaluating change would be the surveillance, evaluation, pulling reports from the electronic health record to check out readmission rates, post-operative infection rates, to see the pre and post education, post-discharge education results of that, and then web-based survey or discharge phone calls. So we want to know if the patient understands the material, understands how to get there, is it easy enough for them, and if they're satisfied with the process. There's a lot of things that would be involved with cost, designers, website, domains, upkeep. It could be several $1,000s, tens of thousands of dollars for a large project like this. Who would be responsible would be the organization, education, IT budgets. It would be a large capital. Policy and technology impacts, quality measurement-based reimbursement. So we want this project focuses around your discharge instructions and your discharge planning, and quantifying the results from that patient education would be difficult. It relies on patient report and survey completion, which may not be consistent or reliable, And then also, you're putting a lot of money into it. Are you getting enough reimbursement back? Enough results to get the reimbursement? And then confidentiality breaches could be, there's a potential for hacking because you're going from a safe portal or website and then linking them to forums and social media. So that there's a potential for a break there. And then cautions with open forums releasing too much information on patient needs. So here are my references. There are 2 pages to encompass all of my research. Thank you for listening.